Welcome, everybody. We're going to start in about 2 minutes. Welcome to today's session on the bottleneck analysis. We'll give it a few more minutes for people to join, and then we'll get started. In the meanwhile, if you joined us online, please go ahead and introduce yourself in the chat, your name, organization, and where you're joining us from. We'd love to see who we have with us today online. We're at the hour, so I'm going to start the session. Welcome, everybody, to today's webinar on the bottleneck analysis, part 2, identifying bottlenecks to scaling up family planning in Uganda and Kenya. This is the second in a series on looking at bottlenecks in family planning. The first was held last year. We have today's session, and then we're planning a third session featuring some of our partners in Latin America, so stay tuned for that. If you go to the next slide, I'll just do a quick introduction. My name is Nandita Pate. I'm a technical officer at WHO in the Department of Sexual and Reproductive Health. And I lead the IBP network, which is a network of civil society organizations working to disseminate guidelines and resources like this one, but also pulling from our partners in the field about what additional research needs to be done, what guidelines need to be developed. And this is a great example of that exchange between our country partners and WHO. So we're very excited to see the results here from Uganda and Kenya. This work is done as part of the FP Accelerator project, which my colleague Rita will be talking about shortly. In a moment, I'll introduce Dr. Rita Cabra, who will provide an overview of the FP project and bottleneck analysis. And then we will go right into country presentations from Uganda and Kenya. We hope to have some time for questions, but if we don't, please feel free to put your questions in the chat or in the Q&A box, and we'll try to respond as we go through. Finally, the webinar will be recorded and posted on the WHO HRP YouTube channel, so you can watch this later on, share it with your colleagues if you want more information. So with that, let me turn it over to Dr. Rita Cabra, seasoned medical doctor working in a number of health areas and really leading the charge with our partners and colleagues on the ground on this bottleneck analysis. So Rita, I'll turn it over to you. Welcome.
Thank you, Nandita. Thank you especially for hosting us at the IBP platform. So thank you also to the IBP. And I hear from Nandita that we have almost around 200 or more participants. So we hope we will have a very great webinar today. So the idea today is, and as Nandita said, this is the second webinar in this series. So the first was held in October, where we heard the experiences and lessons learned from 4 countries, which were Ethiopia, Pakistan, Togo, Cameroon, as well as Nepal. So actually from 5 countries. And today we will again hear the experiences from 2 countries, Kenya and Uganda. So let's start the process. Next, please. Here we would just wanted to emphasize that the idea here is how to scale up and sustain implementation of WHO recommended family planning evidence practices. And this whole work is being done under the project which we call the WHO FP Accelerator Plus project, which has 6 focus areas. And you can see them: post-pregnancy family planning, which includes both post-abortion as well as postpartum. It talks about self-care, task sharing, adolescent, youth sexual reproductive health, social behavioral change, and emerging contraceptives. And throughout these processes, gender and digital interventions have been integrated. Next, please. So in order to scale up evidence-based practices, we started by saying, actually, what is the evidence? What works and what does not? So we did a literature review. We did literature review to identify these strategies both for post-pregnancy family planning, for demand generation, for task sharing, as well as for addressing gender-related barriers, etc. For counseling. And you can see some of the papers which have been published. So a lot of literature review was done to see what works and what does not. However, we felt that what we are getting from this is from people from the academic, people who are actually interested in publishing. But there are many, many, many people who are not publishing, but they have a voice. And we really wanted to hear this voice. So we wanted to have the local players, the local evidence, so that the work is contextualized. We wanted the work to be owned by Ministry of Health, and both the bottlenecks and the solutions to be more specific and achievable. So analysis of this bottleneck is, we realize, is a practical way of addressing some of the important aspects which are required for scaling up. Next, please. So with this approach, the protocol to assess bottlenecks was developed, and this protocol has been published, and it is also on the WHO website, and we will share with you the link so that colleagues who really want to go into detail and see the protocol as well as want to implement it can happily do that. So this is the protocol. Next, please. This protocol, when we developed, we ensured that we use the WHO health system building blocks, knowing very well that scaling up is a multifaceted approach. Hence, these building blocks were used to see what barriers exist where. The protocol has got 3 modules, which focuses on post-pregnancy family planning, social behavioral change, and task sharing to community health workers and auxiliary nurses. The idea here is that countries can pick up 1, 2, or all 3 modules and see what are the barriers and what are the solutions within their context to scale them up. And you will see that many countries have picked up all the 3 modules, while some have focused only on 1 or 2. Next, please. So that was like the framework on which the bottleneck protocol has been established. And then there is also a methodology of how to do this bottleneck analysis. And this has been divided into 3 steps, where the first step includes a preparation. And this preparation includes discussions in country with the Ministry of Health to ensure that they are on board. It includes discussion with other stakeholders who are working in countries. And where required, it includes adaptation of the tool. It is at this stage the countries decide which module they would like to focus on. At this stage, they also go and take their ethical reviews. They do some of them have IRBs on which they share the protocol so that the protocol is approved in the country, all the stakeholders are on board, and so together they work on implementing the protocol. The step 2 involves data collection, which is again done in 3 ways. You do a desk review of the national policy and guidance to see how much are the national policy and the national documents and align with the latest WHO recommendations. Thereafter, you do review the national data, and there are different questionnaires, there are different data points which have to be collected. And you also, countries are encouraged to identify some case studies in each country on each of the topic to see what works, what does not. Now, these case studies are often, in some cases, not published, and hence they are often missed from the literature reviews. Hence, we really wanted to look into these case studies. This also includes key informant interviews, and the key informant interviews include people who are the policymakers, program managers, and they are not only at the global level, but also at the subdivisional level, at the district level, so that we really get to hear what are the bottlenecks in different places, in different districts, in different counties, in different states, as the case may be. Step 3, next step, please. Step 3 is a very important step where the work which has been done in step 1 and 2, which means especially in step 2, where we have collected all the data, come together and we do a consensus building workshop so that all the participants sit together, use a modified Delphi technique, as well as the YYY system to identify why this bottleneck exists. And then they identify solutions to see what is the root cause and how can we address the bottleneck. Next, please. We will not go into much of the details because my colleagues, both from Uganda and Kenya, would actually explain us how they have taken this protocol and implemented them and what are the findings. So this is the current situation. Almost 24 countries have started implementing the bottleneck analysis. Some of them have completed, some are in the process. And interesting thing here, which is really worth noting, is that the implementation is not done only by WHO. At country level, we have UNFPA, we have USAID, we have the USAID, we have the FP 2030, the PAHO, the Reproductive Health Supply Coalition, and many other partners who are working together to implement the protocol. Next, please. Within the as we are implementing the protocol, we also have a monitoring and evaluation framework which we have developed and which is implemented, and where we use the case studies, the country reports, and the after action reviews to be done every 6 months to see how we are progressing. The other thing which we would monitor and we would see is that we conduct an online survey in 26-27, and then we compare it with the current bottleneck approach survey, which has been done in 2024 and now in 2025. And then we try to see how scaling up has happened or not happened. What are some of the changes which have happened in the countries? And this would be very interesting to watch, especially now that the geopolitical situation is changing. But this is how we're trying to put monitoring framework. Next, please. So with this, I think this is a small overview I gave to you. And now I would ask my country colleagues from Uganda and Kenya to present. So first we will hear from Sarah from Uganda, who would take us through the experiences and the process of bottleneck analysis, which was conducted in Uganda. Over to you, Sarah.
Thank you so much, Rita. My name is Sarah, as introduced, and I'll get straight into the experience from Uganda. Next slide. So that's the team from Uganda that I led, and I'll go straight into the goal of the bottleneck. As alluded to by Rita, the goal was to understand the enablers and inhibitors to the scale-up of the 3 EBPs and inform strategies that can accelerate the FP program in the country, and specifically Uganda. Specifically, we want to synthesize what is known about the scale-up of the EBPs, understand the perspectives of the key stakeholders, but also build consensus with all the stakeholders on the most important bottlenecks to the scale-up of the EBPs. This was the assessment methodology that I'm not going to repeat. We adapted this and we conducted an observational cross-sectional assessment, which was national and subnational at levels in Uganda. We did it across the entire health system, including public and private facilities, that is the but also the non-government sector. We wanted to reflect the big contribution of the private sector in family planning. Next, so we approached this in 3 ways. We did a desk review of policy documents and databases for indicators to track the 3 EBPs, which indicators were available, but also we reviewed these documents. We reviewed case reports, we reviewed policy documents, we reviewed clinical guidelines. And these are some of the examples of the documents that we reviewed, in addition to the databases. But also we did case studies. And all this was to answer objective 1, that is checking if the government aligned the standards of implementation of these EPPs to the international standards. And also conducted case studies, a total of 3 case studies, 1 case study per EBP, and all these were conducted. Picked the title of the program or the project, a short description of the project, where the projects were being implemented, who implemented them, and what were the achievements, and then we went on to nib it as rather that facilitated the program, but also we picked the challenges and any other relevant information during the case studies. So we had results from desk reviews and case studies, but also we went ahead and conducted key informant interview survey. So that survey, we had 25 participants for the post-pregnancy family planning. For SBCs, we had 23 participants, and for task sharing, we had 30. And some of the characteristics of these participants were, we had participants from the government, from professional association, from non-government organizations that we also call civil society. We had these participants as policymakers, some were programmers, that means implementing partners, civil society organizations, but also we had clinicians, that is, we had in charges, facility in charges, family planning providers, and community health workers. And all these came from the national, regional, district, and community levels, but we had them having between 1 to 9 years of experience or having worked in such a position. The key informant interview survey analysis was done by getting mean scores. During the analysis or during the survey, we picked ratings across the different government, the different health system blocks, and those ratings were they rated how important the bottleneck was from 1 on a scale of 1 to 5, and the mean score of 4 to 5, which it was dark red, we called it dark red, was a very important bottleneck that needed urgent attention. The one from 3 to 3.99 was light red, important bottleneck, and the one that is light green, which had a rating of between 2 to 2.99, that was a minor bottleneck. Then we had one that was rated from 0.1 to 1.99, dark green, that was not a bottleneck. So as alluded by Rita, these bottlenecks were assessed across the health system building blocks, but within these blocks, we had sub-items that we measured, as you may see on the very last column that has the bottleneck. So as you see here, these were results from the key informant interview survey, an aggregation of these results. And these results are aggregated across the different items under each health system building block. So if you look at postpartum family planning, that is the one that had an important bottleneck under information, clients, SBC, and IEC. That was a 3.0, and the rest of the EBPs had green and light green, which meant there were not bottlenecks. But we went ahead and took these findings along with those from the desk review to the consensus building workshop, which takes me to my next slide. No, so before we went for the consensus building workshop, there is this slide that sort of aggregates. So the previous slide was a breakdown across the different health system building blocks items, but now this shows an aggregation of the building blocks. So we have the seven building blocks, and as you may see, these are box plots that show the median score across every block. And as you can see, the ones that have the red highlight, that is governance, and the green highlight, that is governance and people, these were rated below 2. So they had a median score of below 2. And this meant that there were least important bottlenecks. But when we see the ones that are red, finance and medicine, we see that they have a rating above 2, a median score above 2. And these were the most, had governance, finance, and medicine and technology had the most important bottlenecks under PPFP. Let's move on. So for SBCC, we see that implementation status and governance had the least bottlenecks, while finance and medicines and technology had the most important bottlenecks, as evidenced by the highest median scores. Next slide, please. So for task sharing, we see that human resource and implementation status didn't have bottlenecks because they had a median score of below 2. But then we see that finance and medicines and technology had a median score above 2, and they had the most important bottlenecks. So we see that finance here is that health system building block that had the most important bottlenecks across the 3 EBPs. Then we took these findings, the census building workshops, along with the desk review findings. Next slide. So during the consensus building workshop, we wanted to present these preliminary findings from the assessment exercise and build consensus among the key stakeholders on the most important bottleneck, each EBP scale up, but also identify the root causes and address the challenges and barriers to the scale up. Next slide. So the workshop included the Ministry of Health policymakers, development partners, family planning partners. We had the media, we had researchers and subnational stakeholders. And with subnational stakeholders, I mean the district health managers, the providers of postpartum family planning, and the community health workers. The providers of family planning and the community health workers. And among these included all the key informant interview survey participants. So we had the key stakeholders rank again the importance of each bottleneck across every building block, and this time the ranking ran from 1 on a scale of 1 to 10. And I'll start with governance and financing. So governance and financing, as you may see, we have equity. We have different items under governance and financing. And as we can see, we have orange as PPFP, we have purple as task sharing, and we have green as SBCC. So we see that SBCC had the most important bottlenecks, as all components had a rating of above 8. And we see that PPFP had equity, spending and allocation, insurance and budgeting as bottlenecks, according to the stakeholders. And the task sharing then had equity, regulation and leadership and commitment as bottlenecks. Next slide, please. And when we went to the medicines, technology, service delivery, and human resource, still purple for task sharing, green for SBCC, and orange for postpartum family planning, we see that SBCC still had the most important bottlenecks, with all components having a rating of above 7. And then we have task sharing, have skills and competences, motivation roles, training and education, management supplies, and supervision, as well as coordination being the most important bottlenecks. But for postpartum family planning, it was only infrastructure and supplies. Next. The average rating for people and information, now this is the last building block. We see that SBC still had all components apart from health promotion as important bottlenecks. And the most important was communication and knowledge awareness, data and HMIS. But also we see that task sharing had the most important bottlenecks as client, SBCC, IEC, networks, coordination, consultation, and communication and knowledge. PPFP, the most important bottlenecks were promotion, health promotion, SBCC guidelines and tools, and community engagement. Next slide. So a summary of the previous 3 slides. So a bottleneck was rated important if it had a rating of above 7 on a scale of 10. So for governance and financing across, this is a summary. We see that for all EBPs, the ones in red are the ones that cut across the EBPs, more than 1 EBP. So we see that equity was a bottleneck across all the 3 EBPs. We see leadership and commitment and was a most important bottleneck in SBCC and leadership and commitment. But under medicines and technology, we see that management, supplies and infrastructure were the common bottlenecks across the 3 EBPs. When we move to people and information, we see that client SBCC, communication, knowledge, and awareness were the cross-cutting bottlenecks across the 3 EBPs. Next slide, please. So this is a summary of the proposed solutions to each of the EBPs, rather to each of the bottlenecks. So inadequate communication, knowledge, and awareness. There was a need to strengthen training and mentorship programs on post-pregnancy FP, enhance dissemination of policies, but also there was one on equity and supplies and infrastructure, that is to improve the contraceptive supply chain, to ensure consistent availability, increase access to trained health providers and equipment, provide equitable distribution of EP services. Poor reporting and referral systems of SBCCs, we had to integrate SBCC indicators into the HMIS, standardized referral systems for SBCC. Leadership and commitment, strengthen policy enforcement and ensure commitments for SBCC and task sharing are upheld and implemented at all levels. For regulation and guidance formulation, there was a need to develop comprehensive regulatory frameworks and integrated policies for task sharing. And finance, we needed to allocate dedicated budgets for task sharing initiatives across all levels of care. So we took these findings from the building workshops, the workshop. We took the findings to the family planning technical working group that is chaired by the Commissioner, Reproductive Health, Ministry of Health, and we presented them. And the feedback was that SBCC had very important bottlenecks in all components across the health system blocks. And there was a need to assess the effectiveness of the SBCC interventions in terms of scale, where that is the geographical scale, but also the vertical scale of institutionalization across the levels of care, and the reach, which population groups were being reached. And there was also a need to ensure equity across all the 3 EBPs, and they agreed that the findings were a true representation of the context and were approved. Some of the lessons we learned from this process, the 3 main lessons were that the Ministry of Health leadership was key throughout the process, right from the adaptation of the tools to the validation of results. The Ministry of Health was key in contacting and giving us the list of the key stakeholders in family planning, but also connecting us to the district health subnational level, that is the district health offices, where we had to get to the facilities and the facility in charges and all the stakeholders at that level. And also the Ministry of Health was key at guiding the documents to be reviewed, guiding the whole process. So the leadership from the Ministry of Health was sort of an indication of buy-in, but also it gave us confidence in this exercise. So in some instances, we realized that there was a need to align WHO standards in country operations and standards. And for this, we mean that during the consensus building workshop, we presented findings and we said there was lack of certain policies, for example, policies and regulatory frameworks for task sharing. And the Director General of Curative Services said that we needed not to have a policy on each, but we would integrate some of the needed policies into the existing policies, and we needed to see how. Then WHO needs to know that for some countries, perhaps they're not going to have a standing policy for example, task sharing, but a policy embedded into the broader family planning programming. Stakeholder engagement to interpret the findings was key because as you realize, during our exercise of key informant interview survey, you realize that we had green for SBCC and task sharing. There were no bottlenecks. But when we went to the ranking during the consensus building workshop, then you see that actually the actual bottlenecks that stakeholders believed were bottlenecks as they implemented or as they programmed, as they made policies, were revealed. And that's those are the ones that we built consensus on, and those are the ones that were approved by the family planning technical working group. And with that, I'm going to end at this and hand my colleague from Kenya over to you, Victor.
Thank you very much, Sarah. I'll present from Kenya, Emmanuel. I have my colleagues Victor and Yvonne on call, and they'll respond to questions or comments at the end of the presentation. For Kenya, we have also done quite a bit in terms of this bottlenecks analysis. Kenya selected two modules, that is the PPFP module and the SBC module. We did not select the task shifting module. This was done in consultation with the Ministry of Health and in-country stakeholders. Next. So basically, in terms of the methodology, we did adapt the WHO methodology of the BNA. So the first thing was doing in-country preparations and tool adaptations. There were consultations. And then we did the second process, which was the data collection, and including key informant interviews. It's important to note that Kenya did a modification by doing a focus group discussion. So these focus group discussions are not indicated in the protocol, but through our internal consultations in country, we decided to add some 3 FGDs where we talked to actual service users of family planning services in terms of some of the experiences they were having. So in addition to the desk review from information around users, we did talk to users. Kenya has not yet done the consensus building workshop, and that is basically the next step. I think I'll be capturing that towards the end of the presentation as I highlight the next step. Next. Yeah, in terms of the initial preparations, we did have constant contact between WHO, UNFPA, and the Ministry of Health to discuss how this the study will be done. There was an initial meeting that was done to just build consensus on the methodology and the process, and then onboarding of different consultants to support the activity. Basically doing the desk reviews in the field data collection. And then we did the technical reports, initial reports, and then are looking at doing a consensus building workshop, validation and dissemination, as I talked about that next. Let me talk about, I'll just talk about the key outputs that we have. One was from the desk review. The desk review included different things, and one of the aspects was a data review, and this basically looked at specific indicators and a wide range of metrics around SBC and PPFP and where we are next. And this next slide just shows some of the key data around PPFP, just to highlight the modern contraceptive prevalence of about 56.9, and you can see the trends in the rural and the urban, as well as by age. If you look at those below 20 and above 20 next. These again are additional indicators that were extracted. So for example, if you look at the percentage of women with recent birth who have a postnatal check at almost 80%, noting a very high postnatal check for mothers. Next. And this shows just the data around SBC. For example, if you see the first one, the percentage of women knowing at least 3 modern FP methods are quite high, around 98.7%, and very similar out. Next. Again, more data on SBC. So this data came from, next slide, from the National Data Review, reviewing documents like the DHS, as well as different other data sources. The other important process that we went through was desk review of policy and guidance review documents. And these are just some of the policy documents reviewed, largely right from the health policy to specific policy and guidance documents within the family planning program. Next. And these are some of the insights. We found that the Kenyan policy framework fully supports implementation of PPFP through several things. So, for example, you can see right from the Constitution, we identified that health is a right, and that includes reproductive health, that people have a right to reproductive health services. And then coming to the health policy, then we were able to capture provisions that ensure that people get quality services, including integration for PPFP and SPC. You can see some of the documents reviewed: the National RH Policy, the National Guidelines for Quality Obstetric and Perinatal Care, the National Family Planning Guidelines, 6th edition, actually, with quite specific recommendations, and the handbook, which mothers use quite regularly. These are national level developed documents, but also there was a review of county level, which is more sub-national level documents that also showed alignment in terms of recommendations for PPFP for all mothers. So there were no policy barriers directly identified at this level. Next. This is for SPC, quite similar. A number of documents reviewed. This is just indicative of some of the documents reviewed: the Kenya RMNCH investment case, FP 2030 commitments, which integrate SPC as a cornerstone in terms of FPR uptake, the RH communication strategy, the Kenya health policy, and county level strategy, also providing support to SPC for family planning. Next. We did look at some of the case studies. Next. And have highlighted one interesting one was around using prompts to empower mothers. And basically, this was found, this intervention had increased uptake to PPFP, almost doubling the likelihood of a targeted respondent to utilize PPFP, which was quite remarkable, but also found quite impactful programs around FP and PPFP, for example, the DESI program, which was supported by UK8, among others. So these are a flip quick of some of the case studies that were noted. Next. Next. Yeah, the other thing were the key informant interviews and the focus group discussions. And since it was a focus on getting both national level as well as sub-national level respondents, we did sample 6 counties. And you can see what this blue graph shows is the S-curve. Those are the MCPR rates by county, and the yellow are the counties that were visited. So you can see a good distribution based on MCPR. Next. So 6 counties eventually were selected. We talked to 22 key informants for PPFP and 28 key informants for SPC. Key to note that the key informant tool gathered both scoring, allowed respondents to score, which basically gave scores you saw in the Uganda presentation, but there were also some insights which were given qualitative, which I'll summarize after. Next. So these are just the output scores for PPFP. The scale is the same as what was mentioned. Dark red means a very important bottleneck. Red means an important bottleneck. Light green means a minor bottleneck, and dark green means not a bottleneck at all. So the only dark greens were 2. implementation status and people acceptability, but we did have minor, we did have bottlenecks, the light red, the red basically. That's finance and budgeting. You can see finance and insurance, finance and spending, finance and equity. So those came out as bottlenecks. We didn't have a
Seems like we might have.
in terms of next. The other scores were scores for SBC, and as you can see, SBC had an important, but very important bottleneck again around financing, and all the financing and budgeting indicators were important bottlenecks. But SBC had others. For example, we had people communication and awareness. We had information reporting. We had medicine technology supplies. We had service delivery, supervision, human resource training and education, and human resource capacity. Those also were seen as important bottlenecks. Next. Qualitatively, these are some of the insights that came out as important barriers, both from KIIs and FGDs, issues around culture, religious resistance, issues around myths and misinformation, gender dynamics and gender influences on family planning, issues around adolescent access to FP, limited SBC skills among healthcare workers, from fragmentation in coordination, resource constraint, some policy gaps, and weak policy, especially around dissemination of policies that also came out, over-reliance on donor funding, and limited healthcare infrastructure, especially in marginalized areas. So these came out as themes in the qualitative bits of the key informant and FGDs that were conducted. Next. So these are just some of the summary recommendations around insights from where we are so far. Need to revitalize the demand creation. Need to relook at health system strengthening, especially capacity building, service delivery systems, and the service delivery areas. Basically, people providing the people providing the services to the systematic system level capacity building, some behavioral change, messaging and communication, use of gender sensitive approaches, and evidence and information. Basically, use of research evidence for influencing policy and practice around both SBC and PPFP. Next. Yeah, there were a few lessons that were learned. I think one, just to highlight a few, one is the importance of MOH leadership. That was key in the process, as well as adapting to country needs. As you realize, Kenya did add FGDs, but still was able to maintain the fidelity of the protocol. So adapting but maintaining fidelity of the protocol. Next. Yeah, so for Kenya, the next step is to conduct a consensus building workshop. I think Uganda did present up to that, so you can be able to anticipate what enrichment will happen to the data that I've presented and to the insights I've presented in terms as we move forward, as we go into the consensus building. Next. Yeah, at that point, I would like to welcome Rita to do the next slide. Rita.
Thank you so much, Emmanuel. And thank you both to the Uganda as well as to the Kenya team for sharing their experiences, learnings from the bottleneck analysis. You know, the first time we did this one, it took almost an hour. And we know that 20 minutes does not justify the whole the work which was done. But we really had to put it together in time so that it doesn't become a very big webinar. So I'm sure there are many more details which you will be seeing as soon as we start publishing the results with the countries. But the whole idea of bottleneck analysis was to support the scaling up. So countries have identified quite a few solutions, and as you could see both from Uganda and Kenya today, some of them are immediately implementable, so they are short-term solutions and can be done. Some are medium-term and some are long-term. And this is the way we move forward as we are going forward to support countries in implementing these solutions. So this is just to say that BNA is not an end in itself, but it is just a one step to move forward to scaling up evidence-based practices. Next, please. And I'm not going to read, but these are some of the solutions which have been identified within the countries. But because of time, I'm not going pretty far. However, to conclude, we see that the BNA approach has been really uptaken both by partners and member states. So within a period of 1 year and 3 months, we have already got about 24 countries which are on the process. This has been very much championed by UNFPA in many countries, as well as by other partners. FP 2030 has also provided a lot of support, and we have RHRC, which is doing a lot of work in Latin America. So it has really been taken up by many partners, and in every country, the Ministry of Health is leading the show. And as I just said, there are some immediately implementable actions which can be seen, and they require support scaling up. And so again, we call upon all the partners to support the countries in scaling up their solutions which have been identified by them, and so that these context-specific solutions could help in implementing these evidence-based interventions. So it's a promising approach and may stimulate scaling up of evidence-based practices. I think we can close here, and we can here take some of the questions as well as reflections from people who are here. So we are now going to open the floor for question answers and any other inputs. And I know there are some countries which had already implemented and are doing it. So if they have any specific question to ask other colleagues from Uganda and Kenya, please feel free to.
Thanks, Rita. Maybe I did see some questions that maybe I can pose to both Uganda and Kenya because they're similar. One on the logistics. So could the teams share around how long it took to complete the BNA on average? What kinds of resources were required? And then there's another question about the consensus workshop, which likely comes with its own challenges, and how each of the teams navigated these challenges during that consensus workshop process. So maybe we can start with those to both of the teams.
Linda, I could not hear you at all. So is this question to me or to the colleagues from Kenya?
I think the questions are to the colleagues.
Okay, so maybe we ask the question so that they can hear it.
Did our colleagues online, our colleagues from Uganda and Kenya hear?
Yes, I am online. I'm online. I can answer. So about the logistics, it took us about it was the adaptation process that was longer because we had to engage stakeholders to agree to the kind of indicators we had to track, to the kind of documents, to agree to the protocol, to agree to the stakeholders. We did an extensive stakeholder mapping with the stakeholders with guidance from Ministry of Health. So it was the adaptation process that took us longer. It took us, but also when you adapt and then develop the protocol, and then it has to go through the IRB. So, and then the National Council for Science and Technology. So that was about 3 months. And then the implementation. So count 6 months for the actual implementation and all that together but it could be more or less depending on the dynamics in the country. We also, I cannot put a cap on the amount of resources that we needed. I would say that we needed human resource, yes, human resource to conduct, for example, the key informant interview survey, but also we needed resources in terms of financing, and that depends on the scope, especially the geographical scope. How far are you going to go to the national level or subnational level to get to these stakeholders, and how many stakeholders are you engaging? So these are country dynamics that you work out, but I think the planning should be to that detail so that you plan well and get the appropriate resources. Yes, the other question was about, I'll let my colleague from Kenya answer the next question maybe, and also that.
Yes. Okay.
Yeah, go ahead, Victor.
Thanks. And I just wanted to emphasize the timelines definitely will be dependent in terms of the country arrangement. So as Sarah has mentioned, the adaptation phase really does takes some time. The engagement that with the ministry structures, if you have to secure local IRB approvals, then you have to factor in the timelines that the established IRBs will be able to take. And that also have got logistical issues in terms of costing. So, for example, Kenya, some of the IRBs will cost like $1,000. So you just need to have such indication in terms of the resource envelope required. But that adaptation will take 3 months or more because you really want to ensure scheduling of the meetings, take time, securing diary for the core stakeholders will also definitely take time. So you really need to map out those granular details in terms of the logistical support systems required to ensure the adaptation is pretty mainstreamed and there's meaningful engagement of all key stakeholders. And then two, in terms of real implementation, therefore, on the bare minimum, I think 6 months, because once you're done with the adaptation, then you need like 3-4 months, so to speak, to be able to ensure that all the field level processes, analytics, and the generation of technical reports are done. So that's how, for example, the Kenya experience has been. I think that more or less answers the question that was asked. Over and back.
Sarah, there is one more question for you about the consensus workshop. And how was the consensus workshop? Were there any conflicts, and how did you facilitate the workshop?
What exactly is the question asking, Rita?
Were there any challenges? Were there any hurdles you encountered during the process? And if there were
Yes.
any biases, how were they handled?
Yes, there were challenges, of course. We held the national consensus workshop, and most of the family planning stakeholders are, I'm going to use this word for lack of the right word. They're busy people. They're busy, they're engaged, they're away from the central business district, and they're, for example, up country, they're far away, and they're always engaged in programs and so many other things. So we didn't have a challenge mapping them out because we did this with the ministry, but I think what we saw was the fact that they are busy people, and if we needed them to attend in person, we had to send them. We needed to have them mark the dates of their calendars earlier on, give them constant reminders because they can actually miss emails. We had to get someone to call them up on phone calls. So we did use different avenues, messages, phone calls, emails for the same people, for us to make sure that we are always in their face, so to speak, and they never forget to attend the consensus building workshop. And other entry point, which was significant and so strong for us, was the Ministry of Health. We sent these emails through the Ministry of Health, and that is a policy body with under which they all work, and so that gave us a mileage. It gave us mileage because messages coming from the Ministry of Health inviting them to the consensus building workshops also carried some some weight. And for us, like I said, working with the Ministry of Health throughout the process was key, because it gave us mileage. It helped us overcome so many would-be hurdles, and we went over them so smoothly. Yes. And maybe during the consensus building workshop, the actual workshop, we didn't have conflicts. People were given a chance to rate and give solutions in their respective EBP, and we had to honor their ratings. We also had to honor their perspectives of which were the important stakeholders, rather bottlenecks, which were not, and what would be the solutions, because these are the people who are actually implementing or actually making the policies or actually programming. So we had to, there was no conflict at all. Thank you.
And maybe if I may just add a little bit, Rita, I think the consensus building workshop itself by design is the way it is organized is supposed to enable the audience to appreciate the evidence base. So that's why generating a very technical and robust report that is informed by the available evidence across the domains is very useful in terms of guiding the discourse. So the root cause analysis, if you have building workshop to be successful, you also need to be sure that the facilitation takes advantage of the subject matter expert, so to speak, so that the facilitation is rightly done and the audience are brought up to speed in terms of understanding the design architecture of the bottleneck analysis itself as an approach by design, so that we are able to understand the reason why we are asking this why questions, so that by the end of the day, we are able to narrow down to the root causes. So by the time we go through that kind of discourse, the entire constituency is able to understand the guidance and the basis on which we are narrowing down on the root causes. Then I think the other thing, given the service delivery arrangement, for example, Kenya, where we have a devolved health systems arrangement, ensuring that both constituencies, national and county level participation, and also leadership and technical teams are part and parcel of the discussion, so that they can be able to really go deep and generate the real root causes. At that point, then we are able to come to a consensus in terms of what the real bottlenecks are and how to move forward in terms of addressing the jointly identified bottlenecks. So organization of the workshop and facilitation of the workshop, invitation in terms of participation becomes very crucial, over and above the fact that we have to be able to have gone deep in generating a very technical process in terms of reports that present the evidence garnered from desk reviews, from the field level discussions, and from the discourse with the end community beneficiaries. Over.
Thank you, Victor. Nandita, any other questions? Yes, I can see one which I can answer. Is an expectation that the use of DNA would enhance the sustainability of scale up? Yes, that is the whole mission on which we started this work. That when we do the bottleneck analysis, we'll do the root cause analysis, and we will find solutions which are context specific and which are driven from the countries and which they agree to implement. So we think that this will help us in sustainability of scaling up of the interventions. We think Rotary is a very good partner, and as we start moving towards scaling up, we will definitely contact Rotary. And definitely, yes, we will publish this incredible work, and we are hoping that we could do publication from each country, where we would go into details of the experiences, learning, the process they have used. And then we could also try to bring some of the countries together and see whether we have identified some common barriers and common solutions, or are always the solutions very context specific. So the solutions will be context specific, but are the barriers also context specific? So we are looking into it and how to publish it, and sometimes it is also how to get sure that the government agree for the publication. So we are working on that.
Super. So I think we're at time. Thanks, everybody. Again, the webinar will be recorded and posted on the WHO HRP YouTube channel. And we'll be able to share the slides with you as well. So thank you again to all the presenters, to Rita and Como for your leadership, and of course to all the participants joining us today. We had over 100 of you engaging for the whole hour. So thank you. Rita, any last words?
No, thank you so much, and thank you to all the presenters and to IBP and to Nandita for hosting us. Thank you so much.
Thanks, everyone. Bye-bye.
Bye, everyone.
Thanks, everyone. Bye.
Bye.
Bye bye, everyone.